want to welcome the folks from around the country that have connected here with us today. Thank you for joining us, and thank you for carving out some of the time in your busy schedules to learn a little bit about our partners at St. Elizabeth Healthcare and how they are approaching this challenge of closing the diabetic eye exam care gap, how they have done that in the past and how they are doing that moving forward. My name is Morrow. I am the Vice President of Sales here at Iris. I am honored to be your moderator today. In just a second, I'll ask our panelists to introduce themselves, but let me walk through a little bit about what you can expect here over the next 45 minutes or so. As an audience member, my guess is that there will likely be some questions that come up through the course of the conversation, and we welcome those questions. There is an option at the bottom of your screen where you can click the Q&A button, and that will enable you to type in a question that will come to this group. We will be able to see those questions as you submit them, and then based on the appropriateness or timing, we will address as many of those questions through the course of the conversation as possible. We will also carve out some time at the very end of the presentation. If we weren't able to cover any of those questions during the course of our conversation, we will handle those at the end. All right, I believe that we are ready to get started. So I'm going to talk a little bit about St. Elizabeth Healthcare and who they are, and then hand it off to Hank and Dr. Markovich, and they can introduce themselves, and then we will get into the discussion. So St. Elizabeth Healthcare is one of the oldest, largest, and most respected medical providers in the greater Cincinnati area. If you think of that northern Kentucky, southern Ohio footprint, that's right where St. Elizabeth is located. They have over 10,000 associates. They have over 1,200 providers. And within their St. Elizabeth Physicians Medical Group, there's 165 multi-specialty and primary care locations across that Kentucky, Ohio, Southern Indiana location. We're honored to have Hank Kerschen and Dr. Meghan Markovich join us today, and they're going to share some of their experiences over the past few years as it relates to the diabetic eye exam. Hank, spend a few seconds and tell the audience a little bit about yourself and some introductions, please.
Yeah, hello, my name's Hank Kerschen. I am the Assistant Vice President of Primary Care and Clinical Transformation at St. Elizabeth Physicians, which is the physician group that's affiliated with St. Elizabeth Healthcare. We're a 700 provider group. About 250 of those are primary care, spread across the entire northern Kentucky market. My role really is to oversee the operations of both the primary care enterprise as well as most of the population health support infrastructure that exists inside St. Elizabeth. So that includes everything from ambulatory pharmacy and care management and social work to a lot of the IT and technology work that happens behind the scenes to try to make sure that we're delivering the highest quality of care we can. So that's how I got connected to Iris and where that plays into my world. And I'll let Dr. Markovich introduce herself.
Yeah, I'm Dr. Meghan Markovich, and I'm currently a practicing primary care provider. And then I'm also the physician director of our value-based performance department. And so I work along with Hank on our payers and contracted measures, as well as the population health for the northern Kentucky area.
Fantastic. We are honored and proud to have you both join us today to share your experiences as it relates to the Iris Diabetic Eye Exam program. Let's set the stage a little bit here. I know that this group in particular is keenly aware of the challenge as it's related to the diabetic eye exam. We know that there are roughly 30 million patients in the US today with a current active diagnosis of diabetes. There's many, many more that are impacted with a pre-diabetes diagnosis. Diabetes affects roughly 10% of the overall population of the United States. As a affected condition of that diabetic state, we know that there are a number of issues that diabetics deal with having to do with not only diet and exercise, but clearly the impact on vision is significant with a diabetic patient. We know that diabetic retinopathy is the #1 cause of blindness in working age adults today. That's not just amongst the diabetic population, that is amongst the general population in the US. It is a real problem and a real challenge. And I know probably most, if not all, of the participants on this conversation today have attempted in one way or the other to try to ensure that your diabetic patients, your diabetic members, receive a critical annual diabetic eye exam. And that's where IRIS comes in. We know that historically this has been a very challenging measure to attain. There are NCQA, HEDIS measures, Medicare Advantage plans, you name it. There are a number of reasons or a number of organizations that drive the adherence to this diabetic eye exam. The reason that that measure exists is because of what you see in front of you, because it is the leading cause of blindness. And if we can do a better job of identifying that disease and that condition early, then we can prevent and slow down the progression of the disease and prevent vision loss. So that's where IRIS comes in. We know that there are a number of patients out there that do have access to eye care, but conversely, there are many others that don't have the right access. And so that's where IRIS comes in, which is to bridge that gap between the diabetic patients who need that crucial annual eye exam and now a tool to help them receive that. This is really the beginning of our relationship with St. Elizabeth. I will tell you that IRIS has been working with St. Elizabeth for approaching 3 years now. So this has been a very proud time for us to have partnered with St. Elizabeth. There are many, many patients that have benefited as a result of this. And I'd like for Dr. Markovich, if you don't mind, since you are in that primary care setting really on a daily or weekly basis, you've seen this IRIS program kind of in action, so to speak. So can you walk the audience through really what this looks like in a clinic-based setting?
Right. So I think, when we first got started as a primary care physician, you're always worried about things taking extra time and having the room and space to do things. But really, the way our workflow is we see the patients first, and then our staff will go back and use that same room to capture the images. And it really only takes, 10 or 15 minutes to get this done. And so patients can just sit in the same room, get their images done. And then, one of the best things is you don't usually have to dilate eyes. So the patients love that too. They stick around a little while longer and then they can leave. And then really it's hands off for us until the results come back. And we've got it integrated into our EMR. And so the results flow directly into my in-basket where I can see them usually later the same day or the next day in the patient's chart. So that we can see those and then obviously reach out to the patient regarding results and refer if necessary at that point. So it's really become just a part of our normal workflow that it doesn't add on a whole lot of extra time, particularly for the provider.
That's great. Thank you for explaining that. And there was a couple of things that you mentioned there, Dr. Markovich. We talked about the Epic interface, which we will get into here in a little bit more detail. You mentioned about workflows, and just so that the audience is aware, there's about 30 current locations amongst physical clinic locations across the St. Elizabeth Physicians Network that are currently providing this exam. And there's not 30 different workflows, but there is the ability to kind of customize based on those locations. And so what Dr. Markovich has just explained makes sense for the majority of those practices, but that's one of the benefits of working with IRIS is that we've got that experience and that ability to customize some of those workflows as needed. So we will talk in more detail about those workflows as well. As St. Elizabeth went through their process of, number one, recognizing that they had a problem that needed fixing, then they went through a process of trying to decide what that fix should look like. Hank was involved from the very beginning in making those decisions on the St. Elizabeth side. So Hank, can walk us through sort of the way that you vetted various solutions out and how you ended up arriving at IRIS?
Yeah, when I first got to St. Elizabeth about 5.5 years ago, we were already having conversations about trying to find a solution to solve this screening issue that we had in our practices. And they'd been talking about it for a little bit of time already. And so it was one of those things that just kept bubbling up to the surface, and we never really made much headway on it. And we talked to several different vendors, several different camera operators, just a whole host of services to try to figure out what was really going to meet our needs and allow us to serve our patients in the most effective way we could. As we went through our due diligence process, and it was pretty thorough. Like I said, it took us a couple years to finally get to the decision and make the move to partner with Iris on this. We talked to a lot of different people trying to find a solution that was going to work. There were a few things that really stood out. One was the fact that they were camera agnostic. So that helped us work on trying to figure out a solution that was going to work for us, because as a multi-specialty group, we wanted to make sure that we had an image quality that our ophthalmology team was going to be able to support, that our primary care physicians were going to be comfortable with, that the whole care team really felt comfortable with the camera that we were going to choose to use. So working with Iris on that and knowing that they had a couple different solutions for us was very helpful. It allowed us to really review imaging quality and make some decisions there. The fact that they had a history of success in working with other partners was hugely beneficial. As an Epic shop, it's vitally important for us that whoever we work with has a clear interface or integration with Epic. And so the fact that they had a history of being able to interface effectively with our EMR was a major decision maker for us. We had plenty of vendors and who didn't operate in the same way, but tried to offer a similar service, who would say, yeah, we can do that. We can interface with Epic. And you'd say, have you done it yet? And they'd go, well, no, but we can do it. And I'm always very leery when somebody tells me that they can do it, but they haven't, because it's just a little scary. So the fact that they had a history of being able to interface effectively was another boon for us. And the other part was really the reading network was a piece that helped solve some challenges for us too, because we have a very small ophthalmology practice. We were concerned about the volume of results that we were expecting to get, being able to have a solution that was going to get a fast result into the hands of the caregivers, be able to get the follow-up care taken care of for our patients. And so being able to partner with Iris and use their reading team as well to support that, as well as the technology that was built into making sure that the images were of a high quality, that the AI worked well. All those pieces really came together and separated Iris from the other vendors that we'd spoken with and the other camera manufacturers that we'd spoken with. And that's really what helped us make the decision to move to Iris. I will say, one of the more telling parts of this whole conversation for me, and I always talk about this when I talk about the decision-making process here, was we'd been talking about this for a couple of years, hadn't made a lot of headway. And finally, one of my physician partners, Dr. Wendt, who's the physician AVP over clinical transformation, we were sitting in the room with our CFO, our CEO, and our COO, and Dr. Wendt said, I think this is just the right thing to do for patients. We have plenty of patients that we're not getting these exams on, and this solves that problem. I think we have to do it. And our executive team said, well, we can't argue with that. If it's something that is going to be better for the patients, we need to do it. And that was pretty telling. And so after 2.5 years of trying to figure it out, I wish you would have said that 2 years earlier. It would have probably solved us a lot of headache. But it really, for us, it's been a huge success. It's been a very streamlined process. The implementation went very quickly and very smoothly for us. And we were pretty demanding, trying to get it into 20-some locations over the course of just a really short time period. And Iris was able to help support that. So really felt like a true partnership in how we worked together, more so than a vendor-client relationship. So.
Well, thank you, Hank. We appreciate that feedback. And let's look at what you guys have been able to accomplish since you have started this partnership. There's been clearly a quality measure impact as well as a financial impact, but most importantly, from the Iris perspective, is the clinical impact. Our mission at Iris, and this has been one of the great aspects of the partnership with St. Elizabeth, our mission is to end preventable blindness. And what you're about to see and hear from both Hank and Dr. Markovich is that we have made a significant impact towards that mission. Hank and Dr. Markovich, walk us through a little bit about these results that you guys have seen since we've started this partnership.
Yeah, I can start with that, and Dr. Markovich, feel free to fill in with more clinical information or whatever you feel is viable. But we rolled this out to all of our primary care locations, and And actually, we had a few business health locations that we didn't include in our initial numbers, and they asked us to then get the product into their hands. And so, and we've gradually moved up. I think we started with initially 24 locations. Now we're up to 31. And so we continue to add where we need it. And so all of our locations have this that operate from a primary care perspective. The thing that I heard most from our physicians when we started rolling this out was, wow, I've been telling this diabetic patient to get their eye exam for 10 years, and they've always said they're going to go do it, and they never do. Or when they do, I don't get the result back, and I don't know what's happened, and it's not in our EMR, and I don't get the information, and know that the gap's actually been closed. And so we were seeing that both on our managed care contract performance and also in our just general quality reporting. And this made it so easy to capture it in the office. The patients like it because it's done. They don't have to make another appointment. They don't have to go somewhere else. They're kind of a captive audience. They're already in the practice. And so that was a huge success for us from a provider engagement perspective, because we were taking care of an issue that they had for years. And the other kind of scary and telling part of it was because these were diabetic patients who hadn't been seen or who probably hadn't had their eye exam for years. We were finding some pretty significant disease down the road. And I think those numbers really surprised us when we first started this. Our overall save rate was somewhere around 10 or 11%, where we were identifying people with vision-threatening disease, where 1 out of every 10 or so were having those issues and maybe didn't even know about it. And so I think for us, that was a little eye-opening wow, that's punny. And
we'll allow it, Hank. That's fine.
Accidental, but it sounded really dumb when I said it. So that was a big piece, though, was being able to finally be able to capture these patients at the point of service, close some care gaps, take care of them, and make sure they get the care down the road that they need. Has been a huge piece of the work.
And I'll just add to that. I think as a primary care provider, one of the most frustrating things is to know what to do with a patient and how to provide that care to them, but not be able to do it. And so to be able to give us that access to be able to do the exam right in the office and not just rely on the patient to follow up, make the appointment, go to the appointment, we could actually physically do the exam there in the office, and we did not have to rely on anyone else to help us out. And so it was giving us back a lot of power to be able to take care of the patient right there in the moment, which is a very nice thing. And, as Hank mentioned, that at the very beginning, I think a lot of the patients we captured off the bat were those quote unquote non-compliant patients that just had not been seen by an ophthalmologist in a very long time. And so we saw quite a bit of pathology. And I think, you can talk to patients about things in theory and percentages, but people just tend to think it won't be me. I'm not the one that's going to lose my eyesight. And so when you can do that test and show them, look, you've got mild disease or you've got significant disease, and show that to them, their whole outlook on that changes. And so they're going to be much more engaged on completing the exam and doing it and following up with the ophthalmologist when they need it. I wanted to touch on that 95% because I think that was one of the biggest hesitancies in the actual practices was, we're going to spend all of this time sitting the patient down, getting these images, and then it's not going to be for anything. And we did struggle at the beginning with some of the imaging, but clearly we learned quickly, and now, the majority of the time, the vast majority of the time, we have gradable images just sit there in the office. And so it really, if you think about it, saves time in the back end because you're not chasing down those old records and trying to integrate them into the EMR. And so just being able to have that high of a success rate is really fantastic.
Yeah, we would agree. And that is one of our organizational goals, is to maintain with our partners the highest level of gradability. Because as you mentioned, Dr. Markovich, to go through the exam itself and have the disappointment on so many levels of having an unsuccessful exam due to a low image quality, nobody wins in that instance, most importantly, the patient. So we'll talk in a few minutes about how we go about increasing that gradability rate, which is a critical aspect to these programs. I'll also point out, as Hank mentioned, the save rate of about 1 in 10 patients. Those are patients who have been diagnosed or have been notated to have sight-threatening disease that presumably did not know that they had that condition because of the lack of historical compliance. So again, we're very proud of the results that St. Elizabeth and Hank and Dr. Markovich have been able to help generate in terms of the identification of disease and then getting that patient in front of the right specialists to properly begin to treat that patient. So obviously one of the things that we know is part of our reality today is COVID. We know that for many reasons, a lot of us are glad that the calendar has turned and we are now in 2021. One of those reasons, of course, is that this now starts a new measurement year for not only the diabetic eye exam measure, but for all of your quality measures in your value-based care programs. However, we'd be remiss if we didn't talk about the impact that COVID has had on this diabetic eye exam challenge over the past 9 months or so. And so what I've asked Hank and Dr. Markovich to do is talk a little bit about some of the things that they did last year and probably also on an ongoing basis. And then in addition to that, moving forward, obviously, this is still an issue that we all are across the country are still dealing with today. And now as focus shifts and we add on the element of vaccinations to the already fairly large burden of identification of COVID, it adds another layer. So I know that in talking to Hank and Dr. Markovich, there were some very specific strategies that they implemented historically and on an ongoing basis. So Dr. Markovich, will you talk to us a little bit about what that impact was as you saw it throughout the spring, summer, and fall last year? And then we can also talk about what you guys are doing moving forward.
Sure. So obviously we flipped pretty quickly to video visits within our practices. And so, you cannot capture those images when you're on a video visit. And we initially thought things were going to improve because over the summer, we did have more patients coming into the offices and a little bit more comfortable, but staff and patients alike were still a little bit hesitant to be in such close proximity. We keep hearing be 6 feet apart, even if you're masked. And so the concept of having somebody very close to your face was uncomfortable for a lot of folks. So that was a struggle, even with the patients in the offices. And then as we hit our secondary surge here in Northern Kentucky, we switched again to more telehealth, particularly for our vulnerable patients, which is exactly who we're trying to screen. So it definitely made it challenging. And we did see our numbers drop, but not unexpected, obviously, with the circumstances. So moving forward, we're just going to have to really focus on anytime we have contact with that patient in the office. If they're there for something else, we're still going to encourage them to get their eye exam while they're in the office so that we can just capture them in the moment in case we don't see them again very quickly.
Makes perfect sense. And it is a reality that continues to be something that everyone is consistently dealing with. Hank, I know you've had some experience. You even mentioned before we got started that a lot of your current day-to-day responsibilities are revolving around vaccine distribution. Talk to us a little bit about how that's impacting the eye exam and maybe how IRIS might in some way be able to fit into that strategy.
Yeah, we're trying to sort through what our actual COVID vaccine process is going to look like as we get out into the practices and have greater access to vaccine on hand. But obviously a portion of the time that happens after the vaccine administration requires some observation and patients to sit around and hang out for 15 minutes to ensure that they're not having an adverse reaction. And so there may be an opportunity as we go through that to also potentially capture some patients, because we know it's going to be a thing that draws them into the practices potentially. We did run into some challenges, obviously, earlier last year when practices were really moving predominantly to a virtual model. You can't do this. And when we have patients who are a little resistant to coming back in because they're scared that the physician practices where all the sick people are, the vaccine will be bringing them in. And so we see it as an opportunity to potentially capture some of those care gaps and close them and hopefully provide more rounded care to all of our patients. So it's something we're talking about. We'll see how it goes when we actually get there. But you know, we try not to let any opportunity go to waste. One thing that I should have mentioned earlier, a big piece of what we do also behind the scenes is we have a missed opportunity report that we share with the practice managers and clinical coordinators that identifies patients who have come in who we didn't complete the exam on. And we really use that as a way to help correct behaviors and kind of figure out what the bottom baseline issue is there to make sure that we're solving for that to clear these care gaps. So our ability to report out on patients who've come in that we didn't get the exam completed for helps drive our ability to get compliant down the road, because we use that as a learning opportunity. So.
And that, Hank, is an important part of what you and Iris are trying to accomplish, which is achieving those goals, whether it's clinical, financial, or quality goals. We've got some data that Hank is going to share with us in just a second on exactly what their impact has been in terms of performance on those measures. But let me take a moment. That I know there's been a couple of questions that have been submitted so far. So let me pause and just address a few of those questions, and we'll have Dr. Markovich and Hank jump in these responses. So the first question that came through was, did each of the 20, now we're close to 30 locations at St. Elizabeth, did each of those locations get their own camera? So Hank, will you talk about that decision-making process? Clearly, you know, there's an economic factor, there's a workflow factor, there's a real estate factor. Talk to us a little bit about how St. Elizabeth decided on camera distribution.
Yeah. Well, we didn't want to create a world of haves and have-nots in our practices. So we knew that if this was something we were going to do, we had to go in fully and do it across the board. We still had, you know, we tried to tier it out in a few locations, and it was amazing how quickly we got feedback that, well, why does so-and-so have the camera and they're able to close these care gaps and I'm not able to? So when the physicians are asking for something, that generally means we did a pretty good job with it. And so we took advantage of that and continued to expand. A big part of it was just ensuring that as the primary caregiver of Northern Kentucky, we felt obligated to make sure that we were providing the same level of service across the community. So we put it in all of our primary care locations. We actually just added our residency program in the Family Practice Center as an expansion site. We do it in our business health practices now. We really try to make sure that wherever someone is getting primary care, they have the opportunity to get this care gap closed and that we can provide the appropriate care for them. We're going to talk in a little bit about how we decided on handheld cameras and why and how that's helped us. But really it was for us, it was about making sure that we provided good coverage of the service across the community.
Okay, great. Thank you for that. Another question that came in, and I'll address this one quickly. One of our participants asked, is there an interface with Iris and eClinicalWorks? Hank talked about the fact that they are an Epic shop and we've got an active interface with Epic. And the short answer is yes. Iris has the ability to build a true bidirectional interface, orders and results interface with any HL7 based platform. And that would of course include eClinicalWorks, but any of the other major platforms from Athena, Allscripts, Greenway, NextGen, you name it. We've got existing clients that have that active interface with all of those various platforms, including Epic, as Hank and Dr. Markovich have seen firsthand. So the answer to that question is yes, we have that interface in place. Another question, Dr. Markovich, you can probably answer this one. The question is, on average, how much staff time does each exam take? Again, as you kind of being in the trenches and seeing this in action, talk a little bit about your observations there. Dr. Markovich, you're on mute. I'm sorry.
Sorry, I brought it out. So it definitely has improved since the beginning. We were much slower, but right now, you know, we've got a system in my office in particular where if I'm seeing the patient and they need an iris, I turn off the computer, I turn off the lights, and we've got timers on each of the doors, and I set the timer for 10 minutes. So there's no staff interaction at that point. They're just waiting until the patient's been dilating on their own, and then they go in and do the images. So it really only takes 5 minutes of their time to go in there, get the images, and then download them. And, you know, it's a seamless process. When the patient's ready and we talk about it, just dim the lights, let the staff know the timer's running, and then when they hear it beep, they can go in and get the images. So it really does not take a whole lot of time. At the beginning, for sure, it's a learning curve, but our staff, you know, are on board and are getting really good at it.
Yeah, as with most things, with practice and repetition comes skill development. So your experience there, Dr. Markovich, is not unusual with respect to that learning curve. I will add to that one of the things that we think is vitally important to the success of these programs is the ongoing support that IRIS offers, not only during the initial implementation phase, and what our clients experience in that implementation phase is hands-on approach. We have the ability, particularly now with COVID, we can implement via a virtual process, or we still have capabilities of coming on site and doing in-person go lives and trainings. That's really a client decision on what you are most comfortable with, whether it's virtual or in person. But then on an ongoing basis, IRIS has a team of folks that are client success directors. And I know Hank has had direct experience with our client success director. That ongoing hand-holding that IRIS provides is crucial to hitting goals and targets year after year. And the numbers that you saw just a few slides ago show that when there is a true ongoing partnership, as Hank mentioned, this wasn't just a one-time transaction. We continue to be partners with the folks at St. Elizabeth. And through our client success team, that's how that ongoing communication and ongoing support happens. That's a crucial piece to that. And I know something that has been a really active component of this program that we've had so far. So thanks for the pause. Those are the questions that have come in. I know that there will be more, so we'll take another few minutes down the road to answer the additional questions that come in there. At this point, let's talk about, we talked about the clinical impact as it relates to diagnoses and pathology identified and saved. Let's talk a little bit now about what St. Elizabeth has seen in terms of the impact on their quality measures as it relates to value-based care and performance programs. Hank and his team have provided this data to us. So Hank, walk us through a little bit about what you've got here in front of you.
Yeah, so it's important to remember the timelines of implementation as we go through this. So for the last few years before we implemented with IRIS, we sat right around a 60% screening rate for our diabetic patients. And we really had a hard time getting above that. And some of it was just patient non-compliance. Some of it was getting the information from local optometrists. Some of it was just not putting it in the right place in the EMR. There were lots of little pieces that didn't work well, that resulted in lower performance than we'd have anticipated or wanted. So as we went through this process, we were curious to see how we were going to perform and what change we'd see. So we went live in September, October of 2018. And that's the blue line that you see on your screen. And so as you can see, over the course of the year, we'd kind of hovered right around that 50 to 60% mark. And within the first couple months of going live, we were able to screen a couple thousand patients and get up to a 72% screening rate by the end of the year. We were pretty excited about that. We felt like we'd made a difference, that we had seen the performance come out the way we were anticipating, and wanted to see what the next year would bring. So the red line is 2019. And our goal here is to achieve 5-star compliance normally across the CMS star ratings. And so as you can see in 2019, we hovered around that 72, 73, 74% and finished the year up above 80%. And really we're on track to continue that work through the beginning of this year. We were screening more than 1,000 patients a month in January, February, and the first part of March. We were on track to do that again. And then when the pandemic hit in 2020, it really had an impact on our ability to screen in the practices because we weren't seeing patients in the practices. And I think in the last 2 weeks of March, we screened 49 patients. And that was a little unsettling to us, but we knew we weren't seeing patients in the practices. And then as we've opened up and gone back into more traditional office visits, we're now back on pace with where we were before, with screening over 1,000 patients a month. using the technology, and it's been really successful for us. It's been a huge benefit to be able to see these numbers move. I'll tell you, one of the fun parts is we had this in our physician incentive plan, obviously, and that's a reason why we got a lot of buy-in behind it and trying to get people engaged in it. But I had a physician tell me, well, I wouldn't have been so upset that you put retinopathy screening on our incentive plan if you guys would have told me you were going to do all the work for me. And that's a big win for us, when oh my gosh, we got it. And so, yeah, this doesn't take physician time really. It takes MA and support staff time. They're the ones who do a lot of the work. The physician is the one who kind of sells it a lot of the time and says, you're here, let's get this, let's make it happen. But after that, once the patient agrees to it, they're on to the next patient, and it falls on the support staff to make sure it gets done. And so I expect that in 2021, we'll surpass our performance in 2019 and be up above the 80-85% screening rate, which would be spectacular for us. We'd feel really proud about the work that we've done to identify and close some of these care gaps and provide good care to patients.
Hank, that brings up a question that one of our audience members has submitted. So now's a really good time to address that. Someone asks about providers actually conducting the exam versus MAs or medical assistants. Dr. Markovich, talk a little bit about who's the one that actually conducts that exam in your office setting.
Yeah, so all of our MAs are the ones that complete it. We do have a backup. Our nurse coordinator also has the skill to do it. But I don't have to turn off the lights. I could literally just leave the room and do nothing and they would do it. But yeah, it's nothing on my end at all. I just say the patient needs an iris and all of the work gets done behind the scenes, and it takes no time from me at all.
Okay. Yeah, and we see that consistently across all of our partners that almost exclusively this is an MA or a tech or someone with the proper training provided from IRIS that can very successfully capture these exams. Dr. Markovich, you also mentioned earlier about the camera type, and we noted on your results page that you were at about 95% success rate, which is conversely, we'll call it only about a 5% unreadable rate. I know that some folks in our audience may have already had some discussions about entering into these types of programs, and we know that there are multiple camera options available. IRIS, as Hank mentioned earlier, we are camera agnostic, and the reason that that's important is because we, as someone who's not a camera manufacturer, we don't try to steer our clients into one particular hardware choice or another. That's actually more of a consultant type role that the folks at IRIS play. And I think back to when St. Elizabeth was going through that decision, that was a big part of that process, was figuring out what was the best camera style for those clinics. Dr. Markovich, can you talk a little bit, and then Hank, I'd be curious on your input as well. Talk a little bit about the handheld camera that you guys ultimately selected some years ago and what you've seen in terms of usability, impact, and success.
I'll start and then Hank, you can finish. But I think the handhelds give us so much more flexibility. So we don't have one designated room that is our IRIS screening room. We can really move patients in and out or keep them in the same room, whatever we want to do. Just as an example, at our old office, which was an interesting office, we only had 2 rooms that we could do IRIS screening because every other office for lighting purposes just wouldn't work. And so we really needed that flexibility to go in and out of those rooms because we're a relatively busy practice. We don't have extra rooms hanging around to do things. So it was nice to have that, that flexible option to move them from one side of the building to the other if for flow reasons we needed to do that. But now, we have a little bit bigger space, so they just stay in the same room. But it gives us the option to do whichever works for us at the time.
Yeah, and initially, one of the big questions that came up was the capital outlay that was going to be required in this, and what was the ROI going to look like, and whether it was going to be a viable business plan as we went through this. And so, one thing at the outset that popped up was just the huge difference in our experience of the cost between a portable and tabletop unit. And so, our ability to get more cameras into the practices from a capital perspective was one of the driving conversation parts. The second piece, to Dr. Markovich's point, is really the portability of it and not having to lock down an exam room or a single room for it as the place. It allows us to be a little more efficient, a little more effective in how we rolled it out, how it's used. There are some downfalls to it, just being totally transparent. There's more likelihood of it getting dropped or put on the charger wrong or something happening. So that you run into some of that, but we had one of the learnings that we took away from it was you needed to have a high-backed chair in the exam rooms where you were going to do this, or have the patients back up against the wall, because when somebody comes at you like that, your first reaction is to slide backwards. And so that really impacted our ability to get good reads. And so there are pluses and minuses to whatever solution you choose, I think, but for us, the initial capital outlay, as well as the flexibility and portability of being able to have it in multiple exam rooms and not really have the room be the limiting factor was a big piece of it.
And I'll just add one final comment to that. Again, because Iris is not a camera manufacturer, we do not have a vested financial interest in whichever piece of hardware our clients ultimately select. In Hank and Dr. Markovich's case, they ended up selecting this camera that's down on the bottom of your slide that you see here. But even amongst the handheld options, there are multiple different selections that vary in terms of price and size and features and technology. And that's part of our job, is to be the consultant when it comes to making those types of decisions, factoring all of the things that Dr. Markovich and Hank have mentioned, not only cost, capital required, but physical location, how much real estate is in the room, what's the skill level of the operators, all of those things factor in. And historically, as you can see, I think Hank and Dr. Markovich both are very comfortable with that decision, primarily because of the results that they have generated. An additional aspect of that camera selection has to do with the technology that Iris provides, regardless of the camera that's selected. And this is a crucial piece that has been a contributor to the success that the folks there at St. Elizabeth have seen, and that is the Iris Enhancement technology. I want Dr. Markovich to spend a second talking a little bit about this, but the high-level view is, regardless of the camera that's selected, every image that's exported to the Iris cloud-based platform goes through a series of algorithm-based enhancements. And the impact of that is it takes what on the left hand of your screen is an okay image, a typical 45-degree fundus photograph, and it turns that image into an extremely high quality, very readable image that you see on the right hand of your screen, which ultimately leads to more successful exam and more importantly, more pathology identified. So in your experience, Dr. Markovich, that enhancement technology of the fundus photographs, what have you seen in terms of the impact there?
So I think it's huge, like you mentioned earlier, for the patient in particular, not to have to come back and repeat an exam and to have those results right away, so that they have, that respect for the equipment and know that they're going to get good results. And it's been really helpful for our staff not to have to redo things or bring the patient back. So it's very nice to have that success rate and that optimization, if you will.
Yeah, and that's from the beginning of when Iris was first started. Iris recognized that there are a number of elements that go into successful exam. Of course, competency of the camera operator, the environment itself that image is being captured in, the type of hardware that's selected, but also there's technology like this in the background that supports that exam capture process that allows our partners to maximize their success rate and increase that buy-in, as Dr. Markovich just explained. I know there's been a couple of other questions, so let me take another pause at this moment, and we'll kind of go through a few of those as they have come through. There's been a handful of questions related to CPT, coding, fee for service. I know we're going to talk about that in just a minute. So for anyone that submitted that question, just hold that thought and we will get to that here very quickly. There's also been questions on, let me scroll through here. We talked about provider time. Oh, okay. So that covers the questions that have been submitted. So really, the timing is perfect. Let's talk about clearly the clinical impact is the driving force behind why health systems like St. Elizabeth make this decision. Clearly, there's a quality impact too. Hank walked you through the improvements that they've seen over time in their quality measures. But we'd be naive not to mention the financial impact. There's a cost to doing this, of acquiring those cameras. So I've asked Hank to spend a little bit of time talking about the financial impact. We will definitely include the fee-for-service component in this discussion. I'm happy to jump in and provide our perspective as well. But Hank, spend a minute or two talking about what you guys have seen as a health system in terms of the financial impact.
Yeah, so I'll preface all of this by saying I'm not a biller, I'm not a coder, and I always get myself in trouble when I start talking through our rev cycle process and whatever we're going to do. So that's my caveat as we go through this. But I will say that at least from a business plan and ROI perspective, this has been a huge success for us. We feel that within the first 6 months we had overcome the capital outlay, and it was a quite frankly, the ROI on it was phenomenal. We've had great payer uptake on it. We did have to battle one at the beginning of this, but we've overcome that hurdle. We don't run into financial class issues for the most part, or payer class issues for the most part. We really seem to get good acceptance of this. And we've seen that performance hit our value-based contracts. We've been able to, it's hard to really, in a lot of ways, identify exactly what revenues coming in from a value-based contracting perspective, dedicated to certain specific measures depending on the type of contract. But we feel pretty comfortable saying that over the last couple of years, we've seen somewhere in excess of $300,000 come back in our value-based contracts just from our diabetic retinopathy screening. So that's not a huge number on a couple billion, but it's a big enough number to cover a couple of care managers and help us do other work. So we feel very good about the work that's happened there and the value that we get out of it from a value-based contracting perspective. We also see payment coming in on the fee-for-service side, so it does work out for us from a sheer math perspective. And then when you account for the fact that we are finding disease, we are taking care of patients who otherwise might have fallen through the cracks. This has been a major success for us. We feel really good about it. I think it's one of those things that I always say, if I'd have known that we were going to get the outcomes that we've seen, I would have pushed a lot harder. That 2-year conversation probably really should have taken just a couple months to get done. We don't look back at it at all and go, oh, we should have done this, or this. We feel very good about what we've done with it. And from a financial perspective, it's been a success for us. And from a patient care and outcomes perspective, it's been a success for us. It also links up, we do find some risk adjustment factor that aligns with it and helps us as we look at our overall medical loss reports on some of our value-based contracts. You can actually see some impact there. We do a pretty good job on capturing the HCC scores and risk adjustment factors across our organization. Dr. Markovich spends a lot of time educating our providers on how that works and what success looks like for us. And we feel really good that this has been a piece that has allowed us to capture some parts that wouldn't have made it into that component for us. So again, overall, I think for us, it's been a patient outcome success. It's been a financial success. We're seeing the impact in how we perform in our managed care contracts, and we're pretty pleased with it.
I'll add just a couple of comments from an Irish perspective. So like Hank, we are not billing experts. We are not a billing company. Iris does not submit claims for any exam conducted with any partner. Okay, so with that as the backdrop, what I can share with you is what we've learned from our experiences with clients like St. Elizabeth. And that is the most typical way that our clients are submitting for reimbursement is the use of a CPT code that's 92250. That code is defined as image capture and interpretation. And that code is submitted by the ordering physician most often across our client base. That would be, let's say that Dr. Markovich herself orders this exam for one of her patients one day. then that's the initiation of that dynamic financial transaction through our EMR comes from that ordering primary care physician. We do provide the interpretation services through our reading network that Hank mentioned earlier, but our readers are not submitting claims for the professional component of this. We assign that right through our contractual relationships over to our primary care partners, and so they are managing both the technical and the professional components of 92250. That is what we have seen. That is what we've observed from our clients. As with most things in life, there are exceptions and there might be other ways to handle this, but the overwhelming majority of our clients do indeed handle the claim submission process that way that I've just described. The second thing I would add, as Hank mentioned, from a RAF standpoint, with these risk-based contracts that are becoming more and more prevalent, that's an additional benefit of that bidirectional EMR interface, in that as we return the result and the ICD-9 codes back to our clients, that assists in the electronic documentation of the higher level of complication from a RAF and HCC standpoint. So while it makes for a more efficient program for an ordering and resulting standpoint, it also benefits systems like St. Elizabeth, who are pretty heavily involved in risk-based contracts. So Hank, I appreciate your perspective there. A final topic that I'd ask Dr. Markovich to talk through, and that is, we know that purchasing and implementing new technologies, that alone doesn't guarantee a successful program. You've got to have the culture within an organization that embraces these types of changes and that can ultimately be a committed partner. And Dr. Markovich has seen this herself firsthand in terms of her own clinic, but across the entire St. Elizabeth Physicians Group. Talk a little bit, if you don't mind, Dr. Markovich, about what you've seen that works in terms of staff and clinician buy-in for this program.
Yeah, so I think initially, like Hank mentioned earlier, it was on the provider incentive. So there was a measure that we were tracking through the year on how we were doing as a group on our retinopathy screening. So I think, financial incentives always speaks to people. So providers were a little bit motivated by that. It was on staff incentives, so they had that. But really, when it comes down to it, most people in healthcare are swayed by personal experience. And so, when they see that patient that, for instance, has not had their screening in years, and then they finally get one done and have disease, and they come back the next time and thank you for finding this so that they can get better and know that it's treatable. It's just so rewarding to have that. So once you get people going and then you get some of those success stories, the momentum really just goes from there to really make people understand the why. This isn't just a checkbox that we're doing. This is really an important screening tool to find disease that's treatable and that we can impact people's lives. So once you get going and get that into the mindset of everyone, I think it's an easier push to say this really doesn't take a whole lot of effort, but the gain could be huge.
Yeah, it's a powerful story when you can identify those successes that have true impact on patients' lives. When I've heard our partners speak to their patients about the fact that we've identified pathology that potentially could have been sight-threatening, potentially leading to vision loss, that's a very powerful conversation that then has engagement impact with staff and providers alike. I will add one comment to that, and that is Dr. Markovich mentioned those iris saves earlier. That's that sight-threatening pathology. That data is provided by IRIS. We provide all of our clients with a real-time analytics dashboard that helps our clients to track and document a number of different measures. The slide that we showed earlier with the various boxes, that came directly from St. Elizabeth's real-time dashboard. So being able to provide that data to our clients on gradability, on pathology identified, on saves, it not only helps our clients to make sure that they are tracking towards their own goals, whether that's a compliance number or a value-based care impact or an ROI, it also allows exactly what Dr. Markovich is talking about, which is it helps us share those stories of the clinical successes that have been identified. The client success director builds and maintains that customized analytics dashboard for every single client that we have. And that's a truly unique aspect of what we do that has contributed to the success of not only the program there at St. Elizabeth, but of all of our partners across the country. I know we only have a few more minutes left, so I wanted to see if we had any final questions. These are typically things that get asked of us and of our partners. We've addressed most of them. We've talked about the ease of use of the cameras, particularly the handheld cameras, which the folks at St. Elizabeth are using. We've talked about the time that it takes. I'll talk about the last question here in just a second, but Dr. Markovich, from a clinician's perspective, will you address that first question on whether or not this replaces a visit to an eye care professional?
Sure. So it does not replace that visit to the eye care professional because, obviously we're not checking your vision and prescribing glasses and really looking at that full picture. But like I said, it's a screening tool, and it's such an effective tool at, motivating those patients that, don't want to go, or, just to keep folks, aware of the fact that this is something that you should be doing on a, regular basis. So, and I didn't mention this earlier, but I think one of the biggest things for some of our patients is that when we can capture them in the office and not have them, pay the $45 copay to see a specialist, but then say, what, you have something going on, they're much more willing to go out and do that as a secondary follow-up. And so, while it doesn't replace it, it certainly can be motivational for a lot of folks.
And we completely agree with that. Iris has never positioned ourselves as a replacement for an eye care professional. In practice, Hank mentioned it in the very beginning, for years, you've been asking your diabetics to go see their eye care professionals, to go see their optometrist or their ophthalmologist. And in some cases, they do go, which is great. That's what we all want. Iris is designed for that patient who, for whatever reason, has not been able to visit their eye care professional, whether it's just lack of compliance, lack of access, patient misunderstanding. There's a number of reasons that go into that. So we are in complete alignment with what Dr. Markovich has said in terms of this replacing a visit to their eye doctor. I'll spend the last few seconds talking about that last line here, which is about artificial intelligence. There's obviously been a lot of talk across the entire healthcare landscape of the growth and proliferation of artificial intelligence. I think it's widely accepted that it's a reality more than most specialties as it comes to ophthalmology and eye care. There's some real AI advancements out there within the world, and that has to do also with the diabetic eye exam program. I will tell you that every exam that Iris administers still today does include a human interpretation, but there are AI elements to the platform that are utilized in the background from a technology standpoint. The benefit of continuing to have a human reader is not only the ability to provide diagnostic results on severity, so whether it's mild, moderate, severe, or proliferative, but there's also the benefit that only a human can provide at this time versus when you compare it to an autonomous program, and that is the ability to notate suspected conditions. An iris result will provide a suspicion of glaucoma if it is identified by the eye care professional, a suspicion of cataracts, wet or dry macular degeneration, hypertensive retinopathy, and there's others where that could be notated on the final result as a suspected additional condition on top of any diagnosed retinopathy or macular edema. So that is today the benefit of continuing to have the human involvement. There's some financial implications there as well. We do agree that the future of these programs will involve some level of artificial intelligence, but today, from a practical standpoint, the most impactful questions in our impactful programs involve the human element from an interpretation standpoint. So we are right at our time limit. I want to thank both Hank and Dr. Markovich for their time and their participation in the conversation. Hopefully our audience members have been able to get their questions answered and have learned from your experiences. If there is anything that we can address in further detail, please feel free to reach out through visiting our website. And we are happy to schedule additional detailed conversations. So with that, we'll sign off. Thank you, Hank. Thank you, Dr. Markovich. Thank you to our audience, and we wish the best and hope a successful 2021 to all of our participants. Take care.